Welcome everybody, to today's webinar on value-based care. I presume that everybody knows the acronym VBC, and if you're on this call, you hopefully are interested in understanding a little bit more about how to succeed in a value-based care environment. So I'm David Gregory, principal with Baker Tilly. I'm happy to have you with us today, and we're going to try to at least deliver to you 4 to 6 kind of pithy observations about value-based care, where it sits, what your role might be in it, and how to succeed, even though there's been some failures that we'll certainly talk about in terms of lessons learned in value-based care. But again, happy to have you aboard. I've been in the managed care business for most of my career, which is 30 years plus. And then my colleagues, Heather and Michelle, are equally, well, maybe not equally experienced in terms of long in the tooth, but certainly have the depth of experience that certainly qualify them to be on this call. So I'm going to ask them to introduce themselves real quick. So Heather, do you want to go first and introduce yourself?
Yeah, absolutely. Thanks, David. My name is Heather Herc. I'm a director in our healthcare consulting practice over at Baker Tilly. I have been working with Baker Tilly in the payment transformation or value-based care space for just over 12 years now. A lot of the time that I have spent with clients has been relating to helping transform their business processes and especially their analytics as it relates to value-based care programs and strategies.
And Michelle?
Yep. Hey there. Hi, I'm Michelle Ray. I'm relatively new to Baker Tilly. I'm a senior manager here. My background has been similar to David's, I think, like 30 plus years. Hate to date myself, but largely on the payer side. I've worked in health plan operations for startups and established health plans for the last several years, some ACOs and provider organizations, and looking forward to having a good conversation with you guys today.
Great. Thanks, ladies. And just to kind of set the table, many of you may know, because we recognize some names on the registration list, but Baker Tilly is serving 3 primary audiences in the healthcare space: providers, which is hospitals, nursing homes, physician groups, et cetera; payers, and Heather and Michelle just indicated that a lot of their background is payer side, although Michelle, I think, would also indicate that she's got some provider side experience as well. I have both. And then the third customer stakeholder segment that we serve is life sciences companies. And I'm involved in that part of the business. And you will hear us calling out life sciences in addition to the payer provider. But we think that one of the things that makes Baker Tilly unique on this topic is the fact that we're actively working with all 3 of those stakeholders: payers, providers, and life sciences companies on a daily basis, and look forward to kind of imparting some insights based on that experience that we've got. So let's jump in. So learning objectives for today. I don't think you're going to find anything super surprising here, right? But hopefully we're going to do the blocking and tackling that you're most interested in. We're going to first talk about the challenges, the obstacles. You've probably been on your share of webinars talking about, why value-based care isn't as proliferated as many would have thought it would be, because I think we can all agree that the rollout of value-based care has been slower than expected, much more regional in nature, right? And varied. Some things work in some regions that don't work in other regions, right? There is no one size fits all. But there's a lot of lessons learned out there because there's a fair number of failures around value-based care. We're going to talk about those, but we're also, good news is, we're also going to talk about some of the upside success stories and what were the keys to getting that success. And so hopefully you can learn something from that. The second thing we're going to be talking about is, the expectations and requirements of the 3 organizations in terms of implementing value-based care, because everybody can talk about value-based care. Everybody can even sign an agreement, that says that value-based care is going to govern a relationship, but then implementing it, right? And I think that's really where this webinar is going to sit today, is talking about when the rubber meets the road, you have to implement these programs. Easier said than done. certainly we want to kind of help you understand the roles that are best fit for each of the three stakeholders. Because if you do align the roles and the expectations and make them complementary, that's when success happens, right? When the payers are doing their thing that they're strong at, when the providers are doing their thing that they're strong at, and when the life sciences companies introduce their really deep expertise of the disease-specific area that they're involved in, all three of those together can be a pretty powerful link to value-based care. The third thing we're going to talk about are best practices, of course, and we talked about the fact that we're going to talk about some successes along the way, again, with a bent on the implementation of value-based care. So those are our learning objectives for today. And again, why don't we just, without further ado, why don't we dig in? Heather?
Yep, thanks, David. So one of the things we wanted to start out with was just a little bit of context setting on value-based care. Value-based care spans such a broad volume of different types of programs and models out there. We wanted to show the Healthcare Payment and Learning Action Network continuum for alternative payment models. The HCP LAN is a group of both public and private healthcare leaders that are dedicated to providing thought leadership, strategic direction, and ongoing support to accelerate our care system's adoption of these value-based care or alternative payment models. And their goal really is to help accelerate movement and adoption of two-sided alternative payments. In pursuit of this goal, they've released a framework that's shown on this screen here that allows for us in the industry to use a common vocabulary when we talk about value-based care programs or alternative payment models. So if we just quickly walk through this framework, on the left-hand side, you'll see your category 1 traditional fee-for-service programs. These are the traditional payments based on volume of service rather than quality or value. As you move up into category 2, here's where you still have your fee-for-service payments, but at least a portion of the payments vary based on the quality or efficiency of healthcare delivery. So these are programs that have pay-for-reporting or pay-for-performance type provisions, and it requires a little bit more integration than traditional fee-for-service only. Moving up the continuum further, you get into your alternative payment models that are built on fee-for-service architecture still, but some of the payment is linked to the effective management of a segment of the population or can be kind of an episode of care. Payments are still triggered by delivery of service, but there's an opportunity for shared savings with upside risk only, which would be a category 3A program under the HCP LAN framework, or two-sided risk can also exist, which would be more of a 3B category. And then furthest along the spectrum would be your category 4 population-based payments, where payments are no longer directly triggered by service delivery. Rather, clinicians and organizations are paid and responsible for the care of a beneficiary for a much longer period of time. An example of these types of payments can be cancer care programs, for example, where the clinician or organization is responsible for the total cost of care for these populations over time, as opposed to specific services. So just level setting, there are a lot of different flavors of fee for value out there, varying degrees of integration required. And the HCP LAN is a great industry resource to turn to for thought leadership in this space. David, any other thoughts you'd add here? Otherwise, I'll turn it back to you for the first polling question.
No, I think you did a good job. I mean, just to acknowledge that financial risk increases as you elevate from category 1 to category 4, and then also that arrow degree of integration, right? That, when we talk about integration, or when anybody talks about integration, it's all about how well is the hospital communicating with the physicians, is communicating with the payers, is communicating with the life sciences companies, and data integration, right? Not just people integration, but also data integration, right? So the pressure on integration increases with each step along the way for sure. And as we already indicated, there are pockets of success for each of these buckets, but it's more regional than anything else. And I don't know that anybody's declared that there's one model that will be the surviving model in perpetuity. If they have, I think they're premature in declaring that. But certainly this captures almost all of the VBC activity. So as Heather said, we're just level setting and just kind of getting some of the basics out of the way as we advance the conversation. So our first polling question, I believe the event coordinator highlighted the fact that we'll need you to respond to these polling questions in order to qualify for CPE, but we're also very interested in what kind of crowd we have today and what's going on in value-based care land. So in your organization, what is the VBC program furthest along the continuum? So you certainly maybe even proudly could say A, because we actually have clients that are looking to fend off value-based care from a provider standpoint. We'll talk about that in a couple of minutes. Or are you do you have pay for performance, which is B? You had to pay attention to Heather to understand the differences between these answers here. But C is shared savings with upside only. D is shared savings when there's real risk, because upside risk is almost an oxymoron. Downside risk is where it gets real and where the entities may actually have to pay something back because they weren't successful. And then E, partial global capitation or bundle payment, the most advanced. So if you guys could respond to that, we'll keep going on with content. It usually takes about a minute or two for us to get results. We'll share those results with you shortly, and we'll keep moving through the presentation.
Thanks, David. So another important topic that we did want to spend some time on is some reflections from the most recent HCP land report, which was issued this year and reflects the 2022 performance year data that was collected across more than 64 health plans, several states, as well as traditional Medicare, representing ultimately about 264 million people that are covered by an insurance plan. The long short is, the journey to value-based care has definitely been a journey, but the numbers do continue to show increasing adoption of alternative payment models or VBC models. I do want to draw your attention to the left-hand side of the screen here, that 24.5% in the teal of APM dollars that are flowing through those category 3B or 4, where there's downside risk or population-based payments. This is actually up from 19.6% in the prior year. So we are making progress in the industry and moving to more significant risk in VBC models. And then if you take a look at the right-hand side of the page, part of the survey does ask the question to payers on kind of whether they believe APM activity will increase. And in the last reporting year, 72% of respondents did say that they believe APM activity will continue to increase, with the largest increase being in that land category 3B or that downside risk area. So there's clearly some differences depending on what market segment we look at in terms of where we are at in the fee for value spectrum or VBC spectrum. And certainly there's some geographic differences to consider, but I think just in summary, there is continued movement towards accelerating VBC programs, as well as there is an industry stated commitments. For example, CMS has reemphasized their goal of moving all beneficiaries to be linked to alternative payment models by 2030. David, any additional comments here, or otherwise I'll turn it to you for some kind of state of the industry.
I always feel like, the progress isn't what we want it to be as a country, value-based care. But but these numbers do bear out that we are making progress. We may not feel it every day, but as a country, we are inching, towards more, quality incentives to make sure that quality of care is really leading the way, because there's a lot of evidence that says that if you focus on quality, cost will take care of itself. I mean, the literature is replete with publication after publication that focus on quality will lead to cost efficiency. If you do the other, if you completely focus on cost efficiency, you do run the risk of sacrificing quality. I do, obviously value-based care, needs to take both of them into consideration. And I think that while still a lot of this is kind of VBC light, where it's not, huge financial risk, it's still moving the needle at a snail's pace. At least it's moving in the right direction, as Heather just reflected. I got the results of the first polling question. So about half of you have no VBC models. We should have asked if that was intentional or not, but we didn't. So that's a missed opportunity. But about half of you have no VBC models. Another 16% of you have pay for performance as your highest form of VBC, and then 14% upside risk only, and 12% have downside risk, and then there's actually another 9%. So about 20% of you, about 1 in 5 of you, have either downside risk through shared savings or have some sort of partial or global capitation payment. That's somewhat consistent with this chart. So we've got a relatively reflective slice of what the nation looks like on this call, if I'm interpreting those numbers right. So, but thanks for responding, guys. There'll be a couple more of those along the way here. But why don't we go into the next one? This is me, right, Heather? I think we wanted to kind of acknowledge some of the success that's happened in value-based care. I think, really the federal government, is really the one that led the way. 2012, I believe, I think it was about 11 years ago, is when CMS first introduced the readmission reduction program and the value-based purchasing program, et cetera, right? And that was the federal government dipping their toe in the water, and the private payers, kind of followed in kind from there. They were doing some experimentation before then, but it really kind of took off, if you will, in 2012. And, so we turned to the federal government to at least look for some of our success stories, because there's a lot more required reporting and accountability. There is commercial success, and I'm going to talk about some commercial success as well, but the accountability is less in terms of what actually happened with the program, et cetera, right? So you're going to see what's listed here is mostly kind of government-related stuff or Medicare-related stuff, but there's a reason for that, as I just stated, right? So the ACO REACH program, that can't be declared a success yet, but I would say that the reason why it's on this slide is because it took pieces from other successful ACO predecessors, right? The next gen ACO model, et cetera. Not everybody was successful in some of these predecessor ACO models, but there were definitely lessons learned on the positive side. And now REACH is really getting into health equity. There has to be an angle. If you apply to be an ACO REACH participant, you need to be able to demonstrate that you're going to deliver or at least try to close the gap on health disparities and promote health equity, right? Which is different from equality. Equality means everybody's getting the same thing regardless of their need. Equity is everybody getting what they need, which may not be that everybody gets equal, right? So I know I just talked in circles, but it's really that the industry is going that way. And I think it behooves everybody on the call to be thinking about health equity as CMS is with this ACO REACH program. The Making Care Primary, program is also another nod towards the primary care physician and their role in value-based care. The Maryland Primary Care Program is part of the Total Cost of Care program. I recommend highly to everybody on this call, go educate yourself on the Maryland Total Cost of Care program. Okay, the letters that we have on this slide are MDPCP, but it's Maryland TCOC, Total Cost of Care. That's where they took their all-payer model and actually, increased the scope of the model from being hospital focused to being full system focused. The target is to save $1 billion for Medicare this year in 2023, which is the last year of a 5-year program. There is success there, in the Maryland program. Now, you might get some grumblings from Maryland providers. And if we have any Maryland providers on the line, be interested in hearing from you offline. But it is generally considered successful, depending upon your definition of success. But I do recommend that everybody look at it. Total cost of care. It's basically an all-encompassing global budget, that health systems in Maryland get. It's an all-payer model, right? So everybody's operating under the same global budget system. And if that health system can't deliver care within that global budget, they lose. And it's as simple as that, right? And so, and that's via a CMS waiver. For those of you that might not be aware of it, I will say the reason why it's on this slide is because we're aware that several other states are looking at the Medicare Total Cost of Care program to possibly replicate it in their states. And some providers are actually supporting that in other states. So this Maryland model is something that, could, kind of come to a theater near you, in the not too distant future, even if it's in some sort of varied, situation. So I recommend, if you don't know about it, get smart on it. The MSSP program 22 results were, there was some fairly big successes in terms of dollars that were generated. We can certainly, give you all that detail if you're interested offline, but we are talking billions of dollars in savings with a B. And then, just to keep moving along, a commercial example, Humana Medicare Advantage basically had I think it's 23% reduction in the cost of care versus the Medicare fee-for-service world, 23% reduction in the cost of care with no sacrifice in quality, right? It's through a primary care model and some other, kind of cost control and care management, levers that they pulled. But that Humana MA VBC program is worth educating yourself as well on. A couple others to call out that aren't on the slide. The Aetna Sutter joint venture. I'm sorry, the Aetna Banner joint venture. Is which is out on the West Coast in Arizona. For those of you that aren't familiar, that's a joint venture program that's been out there for several years and is still generating savings, along the way. Some of those Aetna joint ventures have not been successful either. So I'm not suggesting that this is a model that everybody should take to the bank, but certainly it is a joint venture between a payer and a provider in a way that they're doing complementary things. They're assigning who's doing care management. They're not kind of allowing it to slip through the cracks, and their data exchange is a best practice in terms of that. That is one of the reasons why value-based care struggles. And that's what Heather deals with on a daily basis, is just trying to get data to the right people at the right time, to make good decisions. And that's still, almost elusive for us as an industry. So, so certainly that, Banner Aetna example is a good one. And Aledade, Aledade with the ALEDEDADE is a primary care network that participates in a lot of ACO activity across the country. They've had some tremendous success saving in the hundreds of millions of dollars. And so just giving you some examples of both federal government success and commercial success in value-based care. As we said, there's plenty of opportunity to talk about what hasn't worked, but just wanted to give you some highlights of what has worked. Next slide. So here's polling question number 2 as we come down to the bottom half hour, and we are about halfway through our presentation, so we're doing pretty well on time here. So how many VBC arrangements does your organization participate in? So we kind of have a clue. If half of you don't have any value-based arrangements, we kind of know where some of you are going to go with this question, but here we go. So is it 10, from the provider side, is it 10% or less of your revenue? Is it more than 10% of your revenue on the provider side? From a payer perspective, C and D are, do you have few providers in value-based arrangements, or do you have most? So that's kind of a subjective evaluation of that, right? And then for those in the audience, life sciences organizations, are you already participating in some sort of value-based arrangement, or are you interested? You aren't participating, but you're interested. And if none of those apply, hit not applicable for us. But I, just wanted to kind of get by stakeholder a feel for what's out there on the value-based side. Great. So again, we'll ask Michelle to now take us through a couple of slides, and then we'll deliver the results of polling question number 2 when they become available. Go ahead, Michelle.
Hey there. Thanks, David. Just wanted to run through what we thought is the business model components and supporting enabling capabilities for implementing value-based contracts. So everything from what you need to consider, culture, strategy, is your organization ready for this? What their relationships are with your network, care delivery, what do you have in place? I think, there's so many considerations, or I know there's so many considerations as far as what you need to consider when implementing value-based contracting, and whether or not your organization is ready for that. Like, where are you in terms of your relationships with the payers? Do you have good relationships? Do you have contacts with them? Also talking about, population health and where you are in terms of payer engagement. I mean, there's just so many factors. I think that oftentimes we have FOMO, and I'm using that term because I have children, fear of missing out. So oftentimes, like, everybody wants to get in the game, but they're not ready to be in the game. And so I think there's just so many different issues and factors that we need to consider when we're considering going to what level we are at when it comes to value-based contracting, similar to like what Heather explored in terms of that spectrum. So again, I think one of the biggest factors that needs to be considered when you're evaluating whether or not you're ready for value-based contracting is your financial tolerance and what it requires. So aside from looking at what your requirements or what your tolerance is, what the investment is. And the investment shouldn't be underestimated for sure, right? There's technology that needs to be involved. What are your platforms? Do you have an EMR? What is your shared data appetite? Can you share data? Can you ingest? Can you digest data? I mean, that's really important. What your relationships are. So not only, oftentimes we work in silos, and I think that's very important as far as the continuum of care. What your relationships are with your fellow physicians, the health systems, your referral network. Do you have the relationships? And if you don't, you need to grow them. I think a big thing for me is operations, right? What are your workflows? Are your workflows efficient? Are there gaps in your workflows? And I would be, I'm going out on a limb here, but I really think there's probably a lot of gaps in operational workflows that need to be closed. And then resources, as far as your human resources, right? That's a big thing. Your vendor relationships, do you have them? Are you maximizing them? I think that's really important. And I think just going back to human resources is, we all know there's shortages at this point, but there's also deficits in terms of training and educational relationships as far as value-based care. And so we really need to focus on that. And then, just some key financial tolerance and best practices so that you need to consider. So as we all know, value-based is not based on volume anymore, right? It's based on outcomes. And I think that was really important during the pandemic because volume obviously decreased big time, right? So if you had some value-based care relationships and they were successful, that worked out pretty well, I would think, for many. So I think that's something really to consider when volume decreases and outcomes is more important. So that's number one. I think also too, in terms of value-based care, you need to consider that it's not immediate, right? So when you submit a claim, to a health plan, generally they turn it around in a prompt time frame, but that's not the case with value-based care. It takes time. It takes time to assess the outcomes, and you just need to be ready and have that appetite for waiting around for that payment. Also, too, just going back to relationships, when you're in a value-based care relationship, you're not alone. There's others that you're dependent upon, in terms of your referral care network and the health system you're involved in. So I think that's really important that you need to consider that you're not by yourself when it comes to that. And then also your appetite for I think David mentioned this downside risk, right? Oftentimes, starting in a value-based care relationship, maybe you shouldn't commit to a downside risk relationship, upside only. Try it out. And I think that's really important. Like I said, don't jump in with all your feet at the same time, but that's something that definitely needs to be considered.
Great. Thanks, Michelle. And before I, it's okay. You can go to the polling question, but I will read the polling question and then I'm going to give you the results from the last polling question. So hopefully that's not too confusing, but polling question number 3, oops, I lost it there. What is your organization's primary concern with value-based programs? Too many metrics. Let me get a paper because I've lost it again. Not meeting contract targets, investment dollars not available. It's not a provider. It's not a priority for our organization, or it's not applicable, right? So I think based on what Michelle and Heather and I have said, those are probably 4 of the top reasons why there's concerns around value-based care, and would love to hear from you guys in terms of what your concerns are. In terms of polling question number 2, while you respond to that one, not surprisingly, of the providers that are doing value-based care, about 55% of you have less than 10% of your revenue is in value-based care arrangements. However, that does mean that 45% of you, more than a handful, do have value-based care arrangements greater than 10%. Now, 10% is not a huge number, but we just drew that threshold because we know that's kind of a national, kind of conservative threshold for sure. But it's about, as I said, about 55% of those that responded or have value-based care it's less than 10%. So it's not moving the needle. Those folks are still getting paid on a fee-for-service basis, regardless of whether quality is good, bad, or indifferent. That's something that we need to kind of address and change over time as much as we possibly can. From the payer standpoint, the responses were equal. Some said that they have few providers in value-based care. Others said they have most. So, there was more than a handful of payers that said that they have most of their providers under value-based care, but there was an equal amount that said they have few of their providers in value-based care. So again, that reinforces the kind of the regionality aspect of value-based care for sure. And then life sciences, this is certainly not a surprise, but for the life sciences companies that are out there, it's just a handful of you that are even interested in value-based care. And I think we got less than a handful that said they're actually participating in value-based care arrangements. So life sciences companies, I think there's an appetite there, but there isn't. It's just not happening. And we can talk as the presentation winds down as to why that might be. But those are the results for polling question number 2. And hopefully I didn't confuse you by launching you on polling question 3 as I brought you those results. But polling question 3 is open. Hopefully you've responded by now. And we'll come back to polling question 3 when the results are available. So we'll keep moving then.
Yeah, I think just one comment, David, is like it would be interesting, and we may not get it from the polling, but what variation of value-based contracting those that are doing it are at, right? Like in terms of downside versus not downside, right? Just where they are in that sort of spectrum.
Yeah. We got a little peek of that with the first question may have touched on downside, and it's a minority, right? I think it definitely is a minority of entities that are, with the downside risk. I mean, and for the providers in the audience, we feel your pain. I mean, 2022 was the worst year for operating margins for the hospital industry as a whole in 2022, and you might be saying, well, why should I take on downside risk the year after our worst year ever? Because there are some hospitals that are, more than a few that are in financial distress. And so therefore their health system is in financial distress if the acute care facility is, and it makes it tough. We had COVID. I think that did suppress a little bit of the VBC progress. And we're going to need to get back on track here for sure. But I do agree that, I think we can conclude that it's a minority, that have the downside risk. So lessons learned. Let's keep moving here. We're about 10 or 12 minutes from concluding, and then we have time for questions. If anybody's got questions, I think we suggested that you, the way that you can submit questions. Please do so if you have them. I've seen a couple come in. So the lessons learned here, I think this is me. So data sharing is critical, and it must be actionable. I think Heather said this well earlier that, and this is Heather's, professional life is all about data sharing, just making sure that payers and providers, and to some extent, life sciences companies have the data available at the right time and right place to make good decisions. It's that fundamental, and it remains that fundamental. And EMR systems are not solving that in and of themselves, right? I mean, Epic and Meditech and Allscripts, the big EMR systems, they cost a lot of money, but they don't necessarily support advanced value-based care programming, right? You cannot rely on the traditional EMR systems, to create the data sharing, that's needed for sure. Now, having said that, the second comment here is that it should be utilized to its fullest extent. there are modules and the information in the EMR is invaluable, right? What's in the medical record, what tests have been already delivered, what tests need to be delivered. There's even some artificial intelligence that's being introduced into the EMR systems now. So it's table stakes, right? I mean, the EMR is table stakes. You still need more data analytics over top of it, but it's really important to have that backbone of an EMR that you're utilizing to its fullest. Investment's essential. Providers just had their worst year ever. Are there investment dollars out there to develop value-based care? I kind of insinuated earlier that there might be some intentional lack of investment in value-based care infrastructure because providers aren't ready for it and don't want to be ready for it. I do believe there is a component of that out there in the market. And then there's other senior execs. I've been on advisory councils where the senior execs literally say that the investment's not worth it. That, if we were to invest $10 million in value-based care infrastructure, whether it was data sharing or care management tools or things of that nature, that there's no guarantee that investment would pay off. Even if they're incurring penalties today, around certain programs where they're not hitting targets, those penalties are not as high as the investment it would take to avoid the penalties. So there's still an undercurrent in the market of figuring out ways to keep fee for service alive as much as possible. Having said that, the train has left the station. Heather's slide earlier shows that there's quite a bit of value-based care contracting going on out there. Even your polling results are showing that at least half of you are participating in value-based agreements, so that's good. Operational assessments, providers, you can't go into it. I think, Michelle, you said it, right? You can't go into it not knowing if you're ready for it. So you got to do operational assessments. We actually have a survey tool that assists providers in understanding how ready they are for risk, with a whole grading system in terms of what level of value-based care are you ready for? Are you ready for just basic pay for performance, or are you ready for capitation based on the survey tool that we have? And Michelle, you already touched on consider a phased-in approach, right? Take value-based care on training wheels, to get started, right? Don't go to capitation out of the gate. We're not the first consultants to say that, but I think it bears repeating. If you are still on the outside looking in terms of participation in value-based care, don't jump a couple of those boxes that Heather presented. Start slow. Start with training wheels. For sure, and then and then grow relationships. With providers and other stakeholders. I think the industry's done a decent job of this. It used to be that the hospital never talked to the nursing home or to the home care agency, right? Or, to the post-acute care services that were out there. But I think the federal government, like the readmission reduction program and things of that nature, at least lit a fuse in terms of the stakeholders talking to each other. And the payer can help that, right? I mean, I think, the payer has a bird's eye view of what's going on from a resource consumption standpoint. And if you can get your payer partner to deliver you data, you can have meaningful conversations with other parts of your continuum of care, with your nursing homes, your post-acute care providers, your home care providers, et cetera, in a meaningful way. I do think there's been some meaningful progress there for sure.
Yeah, David, I would just want to add what you just said, like the phased-in approach to VBC. Like I said, I use that example, FOBO, but if you want to dip your toe in, right? So you don't want to go to 0 to 100 in 5 minutes, and I think that's really important to really just evaluate where you are as an organization, and if you're ready for this.
Yep. Agreed. So the polling question number 3 results, too many metrics was one response in terms of why value-based care may not be a priority for you. And or why it hasn't taken off with you. And that's for those that, this is really the question for those that aren't necessarily participating in any great way, right? And about 20% of you, said that it was too many metrics. Over 30% of you said that it's not meeting the contracting targets. A smaller percent said that investment dollars aren't available. So I guess that's my first surprise of this webinar, is that kind of a minority of you, or at least a smaller subset, maybe in the 20 to 25% range, said that investment is holding you back. I would have thought that would have been a bigger number. And then the smallest number in terms of the positive responses, was it's not a priority for the organization. And so that's actually less than 20% of you that said it's not a priority. So for most of you, value-based care, is some level of priority. And it sounds like investment is not necessarily the main barrier. It's all about the operational readiness and the diversity in the system, right? Because, if you have 12 value-based contracts, you might have, 10 quality metrics to measure in each contract. And, being overly dramatic, it could be a different 10 in each contract, right? And you could be responsible for tracking 120 metrics. That's overly dramatic. But the point is that there's so much variation between the federal government and the commercial plans that you end up, really struggling with just a variety of what's out there from a value-based care standpoint. So thank you again for that response. I think we have one more polling question in the next couple of minutes, but we can move on here. So in terms of planning for 24 and beyond, provider risk readiness and preparedness, right? So we don't need to beat that one up, but I do think that everybody on this call, I think payers are looking to delegate risk. And I think, Heather might have said that earlier, right? But it's the payers aren't the roadblock. They want to transfer the risk. It's the providers, in our estimation, that aren't quite ready for it. And you really need to understand how ready are you for it? Because it can actually be an opportunity. If you are ready for it and you design your contracts appropriately, you can actually do better than fee for service. And let's be clear that, I don't want to come across like value-based care as some cliff and some level of risk that's intolerable. I do think it's important to say before we sign off here that there's opportunity. There's actually opportunity to grow, your revenue if you're ready for it. But if you're not, then you're skating on thin ice. The health plan's role, I think Heather did a nice job of saying that the health plan's role is very important and from a data and enabling standpoint. So I think we touched on that. The inclusion of life sciences. I'm in the middle of having some life sciences companies get involved in the management of diabetes, in pharmacogenomic situations that help doctors and patients make good decisions on which medications are going to work for which patients, and using those kinds of tools, to manage populations better. And so I do think that payers and providers need to think about the life sciences industry as being a potential value add, to risk arrangements. It wouldn't be a value-based, webinar without talking about digital and virtual health applications. There's so many. I mean, the market's flooded with that, and I'll put AI in there too, right? So, you really need to be aware and very discerning about how digital health, can help you, depending upon which side of the fence you're on. Virtual health is coming out of the pandemic. We found that it's more acceptable than any of us ever thought, but still needs some work to be done. And artificial intelligence in healthcare still has a long way to go. I think there's some very targeted areas for AI, but there's also some situations on the clinical side where AI needs to do more learning, right? AI is only as good as the number of learning opportunities that it's given in order to predict what's going to happen going forward. be wary if you're getting a lot of calls from AI vendors, around, clinical settings, because there's still more learning to be done on that side for sure. All right, so I think this is our last polling question that enables you to qualify for the CPE. So, does your organization participate in care management delegation? That's literally where instead of the payer doing the care management, whether it's prior authorization or any kind of care, other types of care management interventions, having that delegated to a provider. So no, not yet is the first choice. We got a couple of flavors of yes there, with a few, and then with a significant number, and then not applicable. So this is our final polling question, as we're about 4 or 5 minutes from the top of the hour here. So if you could please respond to that, and we'll get those results and sign off here. But Michelle, Heather, any final comments that you guys would like to add to make sure we hit everything we wanted to hit today?
No, I think just from my background and my perspective is that I think it's really critical in terms of doing an operational assessment to see if your organization is ready to accept the risk and what degree of risk. Like I can't stress that enough. That's just something that to me I'm married to, if you will.
Yep. And Heather, would you agree that the payers are largely ready to delegate risk? At this, there might be some exceptions, but is that a fair characterization of the current market?
I think there are some complexities just based on like the sheer volume of types of VBC models out there. It's really not a one size fits all, right? What works for one program may not work the same for another program. And I think from the lens of payers, there's a lot of variation in their current state abilities. And I think this also goes into data sharing too, right? Like there are so many different programs with so many different types of information sets, not only raw data, but also like the type of analytics and insights. It can get very difficult for a provider to manage very quickly. So as a payer, I think payers need to consider what are ways that we can make it less complicated for the providers to weed through the information that's being provided, because physicians are already overstaffed. That there's not just one provider stakeholder, it's the actual practitioners, it's the support staff, it's the clinical leadership that need information, and it's not all the same information that needs to be shared.
Yep. Now, that's a great point to end on, and I'll give the polling results here in a second. But boy, just simplifying the message that the data is providing, right? I think healthcare is swimming in data. We've got data from the medical record, we've got data from financial systems, claim systems. There's data all over, which wasn't the case, a decade or two ago. So, again, another advancement in the system. We have a lot of data. Now it's almost data overload. And Heather, that's a great point to kind of conclude on, is the payers, it behooves them with their provider partners and their life sciences partners to kind of simplify the message that the data is sending, and give it in a way that's consumable, right, by lots of different stakeholders. Doctors will interpret information differently than other stakeholders, right? And I think the industry struggles with that on a daily basis in terms of just not only getting the data somewhere, but then also having that data be understandable, which I think was the main part.
Actionable.
And one quick last comment to from a payer perspective, as much as payers would love to delegate whatever it is, right? But value-based, they're also responsible for the oversight and their capabilities to do that, right? And be accountable. So that's something on their side that they need to assess and take
Yep.
into consideration. Yeah.
Yep. Agreed. Well, thank you, Heather and Michelle, and thank you, audience. If you're interested in knowing, I actually, the last polling question, there was, more than a handful, probably about 30% of you said that yes, you are, having a delegated care management program, and that's good. So we do have some folks that are doing more than just the standard pay for performance out there for sure, and so there were plenty of folks that said nothing yet. In fact, about half of the recipients said that, but somewhat encouraging that there is some care management delegation going on out there, because the age old model of having a payer medical director in St. Louis approving a joint replacement in New York, is not exactly an effective model that's sustainable, right? And if you delegate care management and you take it on as the provider, that's local care management, right? That's local, and healthcare is local, right? So the delegation of care management is important. It's good to see that some of you are doing that. So that concludes our webinar for today. Again, thank you for your attention. Appreciate that. We're giving you a minute back. Maybe it's a little bit less than that, but we are finishing on time. Again, look up Baker Tilly if you have an opportunity, and we're glad you were able to join us today. And thank you very much. Have a good day.